Hey there, this is Dr. Evan Osar, developer of the Integrative Movement System and Integrative Movement Specialist Certification. Welcome to this edition of Fitness Insider, where we're going to talk about conditioning of the psoas. We're going to start by taking a look at what's the functional role of the psoas muscle, and then what are some of the controversies and misconceptions about the psoas, which will lead us into a better understanding of why and how to actually condition the psoas so that it improves function versus actually inhibiting function like it does in many of our clients. So let's get started. What's the greatest obstacle to progression? Well, once upon a time we believed the earth was flat until Galileo came along and proved that the earth was round. And with that, he was met with great opposition and therefore house arrested and jailed in his house until he died. We also believed once upon a time that the sun revolved around the earth until Copernicus came along and proved that the earth actually revolves around the sun. So what's the greatest obstacle to progression? It's the illusion of knowledge. It's the things we learn, it's the beliefs we hold true, it's the things that our gurus and leaders tell us that we believe and get quite upset when some of these beliefs get challenged. What's another obstacle to progression? You got it. Our egos. Sometimes we want to believe what we believe. We don't want to hear anything differently because it's a challenge to our ego. But if we can keep an open mind, if we can be open to the possibility that perhaps we didn't hear and or learn all the story about how the body works, then we can actually be open to some of these concepts and ideas that may actually change and dramatically change how our clients and patients live inside their bodies and actually use this information to improve their performance. So let's talk about some of the controversies and how we condition this all-important muscle known as the psoas. First of all, where is it attached to? Well, it attaches to the vertebral bodies and transverse processes and discs of vertebral levels T11, 12, and L1, 2, 3, 4, and 5. So it attaches to every single segment, both the vertebral bodies, the transverse processes, and discs of all those levels. It has fascial attachments to the diaphragm superiorly, to the transverse abdominis as it wraps around and attaches into the TL junction, and it actually also has fascial attachments to the pelvic floor. Distally it attaches to the lesser trochanter, so it blends near the attachment of the iliacus to insert onto the lesser trochanter of the femur. It also has fascial attachments to the pelvic brim. So what does this muscle do? Well, its classical function is hip flexion. Whether we're sitting, standing, running, we all learn in school that the psoas is a classic and primary hip flexor. Well, if that were true, then why would I say that the psoas isn't even needed for hip flexion? A patient of mine, Miss P, in the image to the right, presented with a surgically removed right psoas. I tested her in multiple positions and she did not test weak for hip flexion. So you're saying, okay, so what? She's probably substituting with other hip flexors, and that's true. But then why didn't she test weak when I did the classic psoas test and tested her in multiple positions to try to isolate out the psoas, and she still did not test weak if the psoas is such a primary stabilizer? And then if the psoas is a hip flexor, why does she have abdominal distension after her psoas was removed? Why does she have trunk collapse on the side of her psoas removal? And why does she test weak in trunk flexion on the side of where the psoas was removed? Well, that all leads us to the question, then what the heck does a psoas really do? If we think about it, it attaches to every single vertebrae from T11 to L5, fascially blends with the diaphragm, the transverse abdominis, and the pelvic floor. It has fascial attachments down into the lesser trochanter of the femur and the pelvic brim. It's a lot of fascial attachments in a lot of key areas for muscle that's simply a hip flexor. Well, what that tells us and leads us to believe that it's primarily a muscle of stability. It primarily helps to stabilize the trunk, spine, pelvis, and hip joints. whether we're doing activities such as push-ups, lifting our child, playing sports, or just maintaining overall posture. And this is why my patient that had her psoas removed, her primary complaint was not hip pain, was not an anterior pelvic tilt, it was actually mid-back pain where the psoas attaches to the diaphragm and the transversus abdominis in her mid-back. And when she stood too long or did too much upright activity, she would have incredible amounts of pain right at the origin of where the psoas attaches to. If we think about a child, what's a child trying to do when it pulls its legs in towards its head? When it's trying to hip flex, pull its toes towards its face, what this child is really trying to do is get the weight up onto her TL junction so she can create proper stabilization at that all-important region, the TL junction, the area where the thoracic spine becomes the lumbar spine, the area where the deep abdominal wall sits, the QL, the diaphragm, the psoas, the transversus abdominis, and the multifidi all come together, and even the lats and the lower traps all come together at the TL junction. All these muscles are trying to stabilize that all-important region of the TL junction. So what else does the psoas do? Well, according to Gibbons, it also helps to centrate the femoral head within the acetabulum, so that when we do hip flexion, it can assist hip flexion, but it really helps to stabilize the trunk and spine and pelvis, centrate the hip in the socket, so that as you go through hip flexion, you're able to maintain a relatively centrated hip joint. So that all the other muscles around the hip joint, like your powerful iliacus, your powerful glutes, can all move, hip flex, and extend without changing the position and alignment of the femoral head in the acetabulum. And because of its fascial attachments to the pelvic brim, it can actually help us posterior tilt. Well, doesn't this tight psoas cause an anterior pelvic tilt and contribute to low back pain? That's what we get taught in chiropractic college. That's what we get taught in personal training seminars. That's what we get taught in physical therapy seminars as well. Well, what does the research say? In clients and patients that have ipsilateral atrophy of paraspinal and psoas muscles in unilateral back pain patients with monosegmental degenerative disc disease. So in other words, what it's saying is clients with pain on one side of their back will demonstrate MRI atrophy, that's been measured off MRI studies, will measure atrophy in both the paraspinals, mostly the deep paraspinals, and the psoas muscles in those clients with low back pain. And this sort of confirms an earlier study from 2004 that showed that changes in cross-sectional area of multifidi and psoas in patients with unilateral back pain. So clients that had unilateral back pain from disc bulges and sciatica actually had atrophy and decreased size in both the multifidi and psoas. And so this kind of fits right along with what Hodges, Hydes, Richardson, and the group out of Australia says about the segmental muscles of the spine become atrophied and inhibited in clients with back pain. And this is the exact same thing we see in all our patients and clients that come into our office with low back pain. They have atrophy and inhibition of the deep stabilizers, including the psoas. But doesn't everyone have an anterior pelvic tilt? So if you look at this client of mine who came in with low back pain, what do you see? If you look at her, it looks like she's in an anterior pelvic tilt, and it looks like she's got increased lumbar lordosis. And if you just looked at this image, you would say, yes, she does. I can see it. But if you look more closely, you can actually see that her extension is actually at her TL junction, and she's not in an anterior pelvic tilt. She's actually almost in a posterior pelvic tilt. It's just that her pants make her look so. So you're like, well, I still don't believe it. Well, let's do a Thomas test on her. And what do you really see here? Does she have tight hip flexors? Absolutely not. In fact, if you look at this client and patient, you'll see that she presents with what most of my back pain patients present with. She actually has overstretched hip flexors that tested weak. So again, when we see these postures that look like an anterior pelvic tilt, what we have to do is really analyze where the pelvic tilt is and is not, and where the extension is and is not. In this client, the extension was in her TL junction. She actually had a long lordosis above that, and she was actually in a slight lumbar flexion and even a slight posterior tilt, even though it looks like she's in an anterior tilt. If we don't palpate, if we don't look specifically at our clients, and we just assume that we know what's happening, we're going to miss a lot of key important findings. So like when we look at our Thomas test, we see that she's overstretched and over lengthened in her psoas muscle, and if I continue, or if her trainer continues to stretch out her psoas muscle, she'll continue to have low back pain because of its stability function. And doesn't sitting cause tight hip flexors? Well, what happens when we sit? Take a look at these gentlemen that I took a picture of when I was in a bar. Are either of these gentlemen sitting in an anterior pelvic tilt? No, they're both sitting in a posterior pelvic tilt and lumbar spine flexion. So you may think, well, what about when people sit in a chair with a back or an ergonomic chair? Well, guess what? Most of our clients are sitting exactly like that. They don't sit in an anterior pelvic tilt unless they've been taught to sit in an anterior pelvic tilt. What this does is it inhibits the low, or it overstretches the low back and inhibits the attachments of the psoas and the diaphragm and the QL and the multifidi, and it actually creates weakness and inhibition in these muscles, therefore leading to a lot of the inhibitory causes of destabilized low backs. And also contributes to our tight hamstrings, which continues to pull the pelvis into a further posterior tilt and lumbar spine flexion. So what's the conclusion? Well, we have to challenge convention. Sometimes our information is incorrect, sometimes it's not 100% complete, but we have to challenge what we learn based on what we see and what we test. That's why testing and assessment is so important, and not assuming that we can just look at somebody and know what's going on. Also, psoas is primarily a trunk stabilizer and hip centrator. It can help hip flexion for sure. It assists hip flexion, but it's primarily a trunk and spine stabilizer. Stabilizes also the pelvis and the hip joint itself, and it helps to maintain a centrated hip as the hip goes into flexion. Posture analysis can also be misleading. If we just think we know, or we just look without actually palpating and or assessing our clients, we're going to make a lot of incorrect assumptions. And I say that only because I've done that many times earlier in my career. I learned about the anterior pelvic tilt and thought every single person had an anterior pelvic tilt until I started working with dancers and realized most of them had overstretched psoases and were actually in a posterior tilt, but I still stretched them. I still did all my anterior pelvic tilt protocol until I started to really take a closer look because of clients that didn't get better. So again, make sure you're thorough and do your due diligence and keep an open mind, because next time, in the next edition of Fitness Insider, we're going to look at, so now that we know this information, how do we actually go ahead and condition the psoas? I want to thank you for keeping an open mind. Thank you for your attention. I hope this video served you. And tune in to next edition of Fitness Insider, where we'll show you exactly how to condition the psoas. Thanks so much. This is Dr. Evan Osar with Fitness Education Seminars. Have a great day.